So today we are covering everything from a little embryology mini lecture to renal and reproductive, and it's quite a bit of content. The reason I added the embryology mini lecture is because between renal and reproductive there are a lot of congenital disorders, and actually this is the only etiology we have not yet studied. We left this one for the end, right? Not the end, it's midterms time, but in terms of new physiology, this is it. This is the last one. So when we talk about embryology, you can talk about the normal, and then the abnormal gives you quite a few disease states and disorders that we'll be discussing. And in particular, there are several congenital and embryology-based ones in urinary and reproductive that we talk about anyway. So this was a good spot to put it. I would have loved to have given you embryology and AMP1. There's just no time for it. So throughout AMP1 and 2, I started telling you about this 3-layer disc that you start out as. 3 layers of pancakes is how I've been phrasing it all along, right? So let me get my pointer going here. And if you look right around here, here's where you're at the 3-layer pancake stage. So let me show you what I mean by 3-layer pancake. It's actually just this part. There's 2 fluid-filled spaces here and here. But this part in the middle, that's the 3-layer pancake. It starts obviously as a single cell, and that's going to differentiate, and it's going to become a flat disc, and then that's going to differentiate and ultimately become those 3 layers. We specify that 3-layer phase because that's where the cells have differentiated to a point where you can really do some significant grouping in terms of what they're going to become. With this blue layer, we always color code it in blue. Obviously, real life, it's not blue. That's going to be the ectoderm. And that ectoderm is going to be neural tissue, your brain, your nerves, your spinal cord, including a special kind of tissue called neural crest cells that are actually very diverse in terms of what they become. They can become part of the heart, they become teeth, really random things that neural crest cells become. You also get your integumentary system from ectoderm. That middle layer that we color code in red, that's the mesoderm, and that's going to become all of your connective tissue and your musculoskeletal tissues, as well as reproductive. What else do we have here as a weird outlier? Your heart and blood vessels are in this layer as well. And then finally, this layer right here is going to be the endoderm. We're color coding it in yellow. I call that the gut tube layer. That's going to become your gastrointestinal tract and all associated structures. And that does include your liver, that includes your pancreas. It also includes your lungs. So you actually have your lungs bud off of your gut tube. So let's go backwards for just a second on this and say, okay, here's where you're a 3-layer pancake. That 3-layer pancake is going to turn into a tube first. So it along the sort of lateral edges, it goes from being a flat pancake to curling into a tube this way. And that tube, the closure of that tube along the midline is actually going to have a lot of clinical significance to us. And this is 3 layers, so all 3 layers of this tube have to close, right? So we are going to see what we call tube closure defects. We're going to have body wall closure defects from the ectoderm. We're going to have problems of the gut tube. We're going to have problems of each of these layers. The neural tube is going to also need to form.
Does this just make one big tube with 3 layers or 3 little tubes?
Think of it as 3 progressive tubes out. Think of it like 2 nicks.
Okay.
Yeah. Now that you're a tube, and you're a tube cranial and caudally, now you're going to curve in cranial and caudally. And that's actually going to get you to that sort of fetus shape that you're a little more familiar with. See that right there? Starting to make a little bit of sense, right? At that stage, that's when that neural tube is going to close at the top and the bottom. And then we're going to start to look more and more like a fetus. So to be clear, embryology is the first 12 weeks of development. You're only an embryo for 12 weeks. After 12 weeks, it's the fetal period. So embryology only covers 12 weeks. Any questions about that so far? That was just a big picture overview. This is significant. This slide with the ectoderm, mesoderm, endoderm, and derived things is significant. What this means, because these came from the same cells, is if you have a congenital defect of one, it's more likely to correlate with other congenital defects for that category, right? If you have gut tube problems, it's more likely to go with lung problems. If you have neural crest problems, you may have tooth and heart problems because those things are all derived from neural crest. And so that actually goes a long way to explain some of our congenital defects that have multiple outcomes.
So it's not going to, like, if you have one problem, it's not going to, like, affect your brain because it's different.
In all likelihood, yeah.
Okay.
There's more to it than that when we'll see our teratogens and effects of teratogens that are aside from sort of genetic defects. That can play out a little bit differently, but yes, usually if a cell population is impacted from one of these layers, we can predict what will be affected most likely. Yes.
So that's kind of like in some things, whenever you have like liver problems, you have for ear problems too.
Oh, yeah, or no, it's like something could be in the ears, like form at the same time or something like that.
So that's probably a concept over here, which we'll get to in just a bit. So let's go through some neural crest derivatives. Like I said, neural crest, embryologists love neural crest. It's just a favorite in the field. We're all kind of obsessed with it. And again, because it's so weird, everything from melanocytes are from neural crest. Your adrenal medulla is neural crest cells. I think in AMP2 I described your adrenal medulla as your mini panic brain. And that was intentional because it is derived from neural crest cells. It's derived from something that was originally supposed to be neural tissue, right? Parts of your heart, some of the great vessels associated with your heart are derived from neural crest tissue. And of course, some of your Schwann cells, satellite cells associated with your nervous system. But I really want you to focus on heart. And teeth's not even on here, but it should be. Yeah. We can have cleft palate issues as a result of this defect too. And what we mean by neural crest is, let's go back to the idea of that pancake and that ectoderm that's going to be integument but also neural structures. So you can see there's this kind of ridge right here. It kind of starts to look a little bit like a mustache in some ways. You can see it like a little bit here going bink, bink. So that's what's being portrayed right here. As we develop this sort of groove along the top layer of the pancake, the ectoderm, it's actually going to come up, meet in a tube shape. That's going to be the neural tube, and those things at the crest, that's the neural crest as it's forming that tube. So those green, it's coded in green right here. That's where it's going to meet and form the neural tube. That neural tube is going to be your brain and spinal cord. That green is the neural crest cells that are going to go everywhere in your body and just do all kinds of crazy things that don't seem to be associated with each other. We talked a little bit about the heart last week, but just to reiterate that heart embryology, it is from the mesodermal layer. Your mesoderm is also creating all of your blood vessels. So your heart, if you really want to think of it that way, is like a glorified blood vessel. It has the same tunics as all of your blood vessels. What's up? Blood vessels are derived from mesoderm. So the way your heart's going to form, you're going to start with two blood vessels, and they're actually going to fuse along the midline, and they're going to do a twisty balloon animal thing. Super scientific, right? And again, the significance here is that all of your great vessels emerge from the same trunk that has to develop a septum. Your atria developed together, and you had to develop a couple of septa. Your ventricles developed as one, and they had to develop a septum as well, right? Those had to be separate events. And we did our congenital heart defects last week, and we did refer back to this. I'm just going back to this idea and tying it in. Specifically, one of the things we're going to see today is that Urogenital and anal structures, you actually just started with a cloaca in embryology. You had one cloaca, you had one hole, and again, you had to develop a septum between them. So we will see some fistulas. Some of them can be congenital fistulas, connections that are inappropriate between two passages. So for example, between urinary and gastrointestinal, anus and urethra, for example, can have a congenital fistula, just as a failure of this to develop. That's about it. Are you guys familiar with the word cloaca? Birds have cloaca. Birds have one hole for all of the things. Reproduction, yeah, waste, excretion. It's just the one hole. That's a cloaca. You started that way too, friend. Other significance here, this actually starts closed and has to open at a certain period. So it closes and then it actually opens. There's also a condition called imperforate anus. So that's a fun one too. Yeah, it can be fixed. Now again, embryology issues, congenital defects can be genetically determined or they can be environmentally induced. If it's environmentally induced, it means that mom was exposed to a teratogen. And that means any kind of chemical substance, radiation, virus that can impact the developing embryo. And all that chemical radiation virus has to do is impact very few of those cells in order to affect the entire differentiation of the rest of the stem cell line. Does that statement make sense to you guys? We haven't talked a lot about stem cells so far, so let me know if I need to clarify any of that. Okay, so with teratogen exposure, and again, embryology is just the first 12 weeks, susceptibility depends on the amount of exposure and the timing of exposure. So here's this. If that teratogen exposure happens in the first 2 weeks of embryological development, in all likelihood, that teratogen has impacted enough cells that it's not going to be compatible with life. I know the word miscarriage is scary, but I do want to remind you guys, it's unbelievably common. It's just not spoken about very much. As far as we know, it's around 25% of pregnancies, and honestly, it's probably far more than that. Yeah.
So with the first 2 weeks, could that have happened and then you not really notice?
Exactly.
Like, it could have happened.
Yeah.
You just didn't notice because it was so early?
Exactly, yes. Yeah, your period might be a little late and might be a little heavy and you wouldn't know necessarily. Yeah, pregnancy scares. Exactly. So earlier exposure, the general trend here is that earlier exposure to teratogens is more serious than later exposure to teratogens. So by the time you get through week 3, you're having major morphologic abnormalities. By the time you get to week 8, you're having sort of physiologic defects, minor morphological defects. What's up?
They say most miscarriages happen in the first trimester. Is that because there's like so much that could go wrong?
Yes. Yes. If anybody is interested, I've got several embryology textbooks, and they are pretty upsetting because they use real pictures of real dead babies with all of these defects as a way to demonstrate what goes wrong. And it's the most terrifying thing in the world. It's horrible, but it's also incredibly interesting. You get back onto track after that one. Where is it going with that? Okay, so again, early on, major morphological abnormalities gets less serious with time. And again, embryology is just the first 12 weeks. 12 weeks is differentiation. After 12 weeks, everything's basically differentiated. You have all the basic structures. They're not going to look like their adult form. They still need to develop and become functional. You have lungs, they're not functional lungs. You have a heart, it's not quite a functional heart yet, right? So the fetal period is considered a time of growth rather than differentiation, like you have in embryology. So that's the first trimester thing you were asking about. Yeah, since it's a growth phase, it's more likely to just be issues related to stunted growth or abnormal growth. but you would have all of the structures. Whereas during the embryology period, you can end up with, half of an arm embryologically, or just an arm with a finger coming off of it, and things like that. That's just the way that goes. Or a lack of eyes, or a lack of any of these things. Problems with central nervous system development, anencephaly, microcephaly, things like that. So again, we go from brain to heart to arms, eyes, legs. Ears take a very long time to develop. Then you've got teeth, palate, and external genitalia later on. And I don't want to be like, okay, during week 6, which one are you going to have? That would be a terrible question for me to ask you on a test, right? To ask you which one of these is happening week 6. I'm more interested in the overall trends of it at this point. I'm not entirely sure. Probably the inner ear complexity, if I had to guess. Cochlea and vestibular system, not just the external ear. Yeah. Okay.
Depending on what happens to the fetus, can they determine maybe what caused, like what environmental effect caused it, or is it just like?
It depends. I don't know exactly what they do. I imagine it would just be a history. Like, were you sick? Did we CT you before you knew you were pregnant? Did something else happen? Yep. Again, so this is showing you by week. So week 3, you've already started CNS development. Week 4, you're starting arms, eyes, legs. Week 6, you start teeth and palate. Week 7, you start genitalia. Yeah, it's an overall trend too. It's not that solid. There are a bunch of billboards in my neighborhood that are really, really incorrect about the timing of embryological development. Things that are pro-life, and I'm not going to touch that debate with a 10-foot pole. But a lot of those pro-life signs just are completely incorrect about when things develop. They're just lying to pull on your heartstrings. I think there was one that was saying you can hear by day 14 or something like that, which, like, no, you can't. The answer to that is incorrect. So, any questions about that? So again, teratogenic agents, chemicals, drugs, infectious agents, radiation, alcohol, fetal alcohol syndrome. And of course, it could be genetic. The genetic form would not be environmentally induced. That asterisk is there, by the way. There was an asterisk back a few weeks ago for congenital disorders because I mentioned I wouldn't start talking about it until today. What's up?
So, like, obviously the first few weeks it's hard to know if you're pregnant or not. Like, if you drink or do whatever, is it for sure that this stuff is going to happen?
No.
Okay.
I don't think we've figured out fetal alcohol syndrome in terms of exactly who's going to get it.
Right.
That's the last I've heard on it. It's been a long time since I've heard any evidence on fetal alcohol syndrome. Okay, so you can have a variety of outcomes from environmentally induced congenital disorders, microcephaly, small eyes, being prone to pneumonitis is what that says. Heart defects are really common, splenomegaly, hepatomegaly, petechiae and purpura. So again, there's a lot of cause and effect going on that this picture is really not conveying. It would be systems-based to have each and every one of these. Okay, you guys ready for some kidneys? Did you guys keep your worksheet from renal? Good. Did you look over the worksheet from renal? Yes. One person did. Okay. All right. What are some hormones that act on the kidney? Antidiuretic hormone, which is released by what gland? Pituitary, anterior, posterior. Posterior pituitary releases antidiuretic hormone. What structure is the target within the kidneys, within the nephron? What structure are we targeting with ADH? No, it's not the glomerulus. It's not the DCT. I didn't hear you. What did you say? Collecting duct is the target. The main target for ADH is the collecting duct. What's the function of ADH? Makes you pee less. Excellent. By doing what? Reabsorbing. It inserts aquaporins into the epithelium of the collecting duct, and then water is going to move towards that salty medulla. We got League of Legends in our kidney medullas, right? Salt everywhere. So our first bad thing to happen to your kidneys is going to be insufficiency of ADH, secondary pituitary damage, and we're going to call that diabetes insipidus. This is one of the many reasons when we say diabetes, we can't just say diabetes anymore. You have to say diabetes mellitus type 1, diabetes mellitus type 2, pregnancy-induced diabetes, diabetes insipidus. This has nothing to do with sugar whatsoever. The only thing it has in common with diabetes mellitus is that there are large volumes of dilute urine. That's it. It's also possible to have something called nephrogenic diabetes insipidus, in which the ADH is fine, your pituitary is releasing all the ADH, but the collecting duct cells are non-responsive to it. Does anybody remember what it is that determines a cell's responsiveness to a hormone? Yeah, receptors. Does it have a receptor that works for that hormone? Absolutely, well done. Let's see. Diuretics, you know that diuretics make you pee and antidiuretics make you not pee. Loop diuretics block sodium, potassium, and chloride pumps in the ascending loop of Henle. Some fun pharmacology tie-in for you, but I'm going to move on. Your kidneys release erythropoietin, which does what? Yeah, it triggers your red bone marrow to produce more red blood cells in response to low oxygen. Let's see. Therefore, if you have kidney failure, you're also going to have anemia. There's a bunch of stuff I took out of this chapter. This was sort of a review chapter in many ways, but I left some things in there that I thought I had not covered in AMP2. You guys have probably heard a little bit about urinalysis, serum creatinine, BUN, GFR. Let's see. I don't know if there's a lot to add here. If it smells like ammonia, usually that's because it's been sitting around for a little while. If it smells really bad, it's probably bacteria. What else do I want to add to this? So of course, in normal urinalysis, the color should be pale yellow to amber at the darkest due to urochrome pigments. If it's brown or bright red, it could be hematuria because there's blood cells in the urine. If it's cloudy, it's probably due to white blood cells in the urine, which indicates an infection. If it's dark yellow to orange, it's concentrated. It just means they're dehydrated. And there are drugs and foods that turn urine different colors. Let me see something where I have osmolarity. I'm going to pause for just a second. I'm going to take just a second to go on the sidebar about the difference between osmolality and osmolarity. It's usually not something I teach, but I'm realizing it's significant in other classes. So they are both measures of concentration. How much stuff there is in solution is concentration. Do you have a lot of stuff? Do you have a little stuff? The only difference between these two things is that one of them is a measure of stuff by weight, by mass, and the other is a measure of stuff by volume. So we're going to measure osmolality in kilograms, right? So milliosmolar, I don't even know what that unit is, sorry, per kilogram of solvent. Osmolarity is going to be measured by the liter. And that's really it. So osmolality is weight, osmolarity is volume. Make sense? Okay, so what are we going to use to, what's our unit of measure for osmolality? Kilograms. What's our unit of measure for osmolarity? Liters. Great. Does anybody want to help me come up with a mnemonic device for that? Let's think it through for just a second. Think about L's versus R's. Go for it.
So for osmolarity, you know those people that work out. No, people that go to the gym and work out and they carry a jug of water with them. Like
Sure.
literally a gallon.
Mm-hmm.
So think of gallon, it's like a jug of water.
Right.
Water you can measure liters.
Yeah.
Larry carries around a jug of water.
There you go, Larry. Larry carries around a jug of water. I like it. Or how about Larry carries around a liter of water? Larry carries a liter. Larry carries a liter? We're going with that one? I like it. I'm into it. Okay. So again, urinalysis, we will use certain measures of osmolality, which we now know the units of that are going to be in liters. Wait, no, I said that wrong. Kilograms. There we go. Good catch. It's Larry carrying a liter. Lal is really heavy. He's not going to the gym. I don't know who Lal is. It's a terrible name. It's not working. Just Al. There you go. Al's not going to the gym. Okay, so Al's overweight. There you go. I like it. Larry carries a liter and Al's overweight. Perfect. So we'll use urine osmolality and specific gravity. Normally, they're going to vary normally throughout the day, but we'll still use those as measures. What else do I want to say? Proteinuria, a small amount of protein is okay. A large amount of protein means there's something wrong with glomerular filtration. Glucose, glycosuria, that means there's a lot of glucose that's not undergoing uptake in the cell. That's usually going to be associated with one of our diabetes mellituses. And then epithelial cell casts, red blood cell casts, they actually have some very specific associations. White blood cell casts are associated with renal infections, such as pyelonephritis. Red blood cell casts may indicate inflammation of the glomerulus, which is glomerulonephritis. Here's a scary sounding one. Epithelial cell casts indicate sloughing of tubular cells. So those proximal convoluted tubules, remember those are simple cuboidal cells. They should be in the nephron. They should not be peeing out of the nephron. That means acute tubular necrosis. And as I understand it, that's mostly associated with certain forms of chemotherapy. What's up? The what? I don't know. I stole that photo from the internet. No. Okay, serum creatinine. What's creatinine? It's not creatine. It's related to creatine. Something to do with muscles. Byproduct of muscle something. Yep. Creatinine produced for muscle, which is relatively constant in the absence of muscle breakdown. So yeah, you are using creatine as an alternate energy source. Some people will supplement creatine before going to the gym, right? It's a good way of getting some extra ATP out of the deal. But if you're not supplementing creatine, it should be pretty consistent. We can use that as a measure for kidney function. BUN, blood urea nitrogen. When do you have elevated nitrogen? What's going on with nitrogen? Protein. You get nitrogen from the protein you eat. It's part of the macromolecules of life, which actually we don't get till next week, unfortunately. So nitrogen is going to be found in the backbone of all of your amino acids, and when you have a lot of protein, you're going to break it down and you're going to pee out your nitrogenous wastes in the form of variations on urea and ammonia. That's what urea is. It's just a whole bunch of nitrogen, right? There's your nitrogen. That's a urea molecule, by the way, showing you that it is in fact a nitrogenous waste. If you have an elevated level, usually that means there's a decrease in renal function or a decrease in fluid volume, although it could just be that you had a steak last night. Which is why we have multiple measures for this, right? If somebody just had a steak last night, BUN may be high, we may need other tests to indicate kidney function. That's a pretty general chapter. It's kind of scattered and all over the place. Again, it's because I cut a lot out because there was a lot of review content in it. With your kidneys, you're actually going to have a few ways that your kidneys can mess up. You can have your kidneys mess up before. It could be the blood supply to the kidneys. We would call that a pre-renal disorder. It can be intrarenal, it can be the kidneys themselves that are diseased, or it can be a post-renal disorder, something after the kidneys is problematic, right? So intrarenal disorders, we're within the kidneys for these. And of course, you can have all of your major etiologies: congenital, neoplastic, infectious, obstructive. And now we've got our own little category here, glomerular. What's up?
Sorry, a little bit.
Blood, urea, nitrogen. Congenitally, the embryology for your kidneys is really pretty complicated. You actually form 3 different sets of kidneys progressively. I know, it's really weird. Yeah. Again, with renal agenesis, ultimately it's your last set of kidneys that fail to develop. Agenesis completely means there's no creation of your kidneys. Bilateral agenesis of kidneys is not compatible with life. That's going to be a miscarriage. Unilateral agenesis may actually be okay. If you are born with 1 kidney, probably that 1 kidney is going to be over enlarged compared to a person with 2 kidneys. That's going to be a hypertrophic kidney in response to doing the job of 2 kidneys. And then some kidneys will just be hypoplasic. They will be small, undersized kidneys. That would be an example of a hypoplasic kidney. Again, you can survive with 1 kidney. Humans can survive with 1 kidney. We would decrease protein intake and we would monitor. With neoplasms of the kidneys, fun fact about this one, I've mentioned with neoplasia, most of them are going to travel via the lymphatic system, and a few of them are going to travel via the cardiovascular system. The renal cell carcinomas are actually more likely to metastasize via cardiovascular, hematologically. It's one of the few that does that. Renal cell carcinomas, I actually got to see one of these recently at an autopsy. It is metastatic, that means it is a cancer. There does tend to be a familial basis for it. Problem with our renal cell carcinomas is they are asymptomatic until they are very advanced. Again, you can live with 1 kidney and you're not going to have kidney pain until that tumor is very, very large, right? Again, you can remove a kidney. The question is, what stage are you at? Has there been lymph node involvement? Has it metastasized? Has it gone past the Gerota's fascia, which is the connective tissue that surrounds the kidney? And as you know about neoplastic conditions, connective tissue is a limiting factor for metastasis, right? But if it grows past that connective tissue layer, it's much more likely to metastasize. It's actually a decent stopping point, and it's past time for me to set you guys on a break.